Again, good morning, or wherever it is in your neck of the woods. Uh, this is an interesting discussion that rarely gets brought up at ID conferences. Usually, if it's at IDSA, it occurs maybe once every 3 or 4 years, and usually by the ID person who runs the section at one of the illustrious eye and ear institutes. This talk will cover pretty much all of these things. So how many of you know anything about all these in this room?
Some,
No, it's not a foot, so it's north of the foot. So there's a lot of things to discuss on here. And the first thing is for you to go back to med school and remember what the anatomy of the eye is, because people don't look in eyes anymore, which is really troubling. How many of you have an ophthalmoscope with you that you could look into an eye if you needed to?
the battery's in mine.
Yeah, I know. The batteries in mine.
Corroded out, and I
Yes.
can't get one out.
They're dead. Usually you have to go find somebody that's got one. They used to always have them at the nurse's station, but then people would borrow them, never bring them back, claim that as their own. And so it's kind of a lost art, if you will. When I was a resident here, just 2 weeks ago, you were expected to do an eye exam, and you had your own bottle of 1% Madriacil to dilate the eye. That ceased in my third year when a medical student who had borrowed somebody's Madriacil in the ICU dilated one of the patient's eyes, who was intubated so he could look inside of it, did not tell anyone that he had dilated the eye. The nurses come over and see this guy, look at his eyes and say, oh my God, he's got one blown eye. So he got this whole logic workup. And then finally the med student said, oh, I dilated the eye, and didn't tell anybody. So we were not allowed to do that anymore. So it's kind of a lost art. But a lot of this talk is going to be discussing all those structures in one area or another. And I think it's important for us to remember, kind of what's going on. It's a really very interesting organ in the body because it lets you see. And the bad things that can happen to it are, some of these things are pretty sublime, and some of these things are really, they will get an ID consult, and you need to know what to do. The most common thing, and you probably see it all the time in this institution, is blepharitis, especially in older individuals. There's three types of this. It's a chronic inflammation of the eye. There's seborrheic blepharitis. That's usually more, if you will, a dandruff of the brows and the scalp. Staph infections, if you want to get fancy, they're hordeola, or a sty, as most people would call it. The meibomian glands that sit actually in towards the conjunctiva really are the lipid glands that keep your eye moist. And you can have those get plugged up, and also just because it's lipid gland dysfunction, they're really not infectious. They can be painful, but usually aren't. It's just a large swelling of the eye that if a person wears contact lenses may cause issues with that. And I'll show you some of that in a second. So some of the symptoms of any of these is, irritation or itching, burning, foreign body or gritty sensation, tearing. They may or may not have photosensitivity and may have intermittent blurred vision. So when you're looking at, a lot of this seborrheic dermatitis can be an issue. Bacterial infection, we already talked about, malfunctioning oil glands. If they happen to have rosacea, they're more likely to have one of these issues, mainly being more of a seborrheic dermatitis, the lid. Allergies or bacterial infections with makeups. One of the things that's really unfortunate is that we've seen in the past is eyeliner get infected with Pseudomonas aeruginosa and cause Pseudomonas eye infections. Also, you can have eyelash mites or lice in some people. What mite would you think about involving maybe the eyebrow or the eyelashes? Good thought. Probably not, but it can be, but usually not. There's one that's more common that normally can occupy hair follicles. No. No. Demodex follicularum. Demodex is a mite that usually has a symbiotic relationship, but they can sometimes grow to large numbers and cause issues with it. And the treatment's similar to what you do with a louse. So just something to think about. Other medications like isotretinoin compounds, and these are just some brand names from the past that people use, can increase bacteria on the eyelids, and that can affect tear production. So the first thing to do is look at the eye and see what's going on. Once you've seen it, that's why I put a lot of pictures in this. So if you see it, you're probably going to remember what it is, hopefully. If you see erythema of the lid margins, if you look at elderly patients, you're going to see this not infrequently, because some of this may be going on, especially having subderm of the eye. Eyelash debris is another common thing. Eyelash crusting or eyelid crusting. Salacia or hordeola that we talked about. Eyelash loss because of chronic infection. And having kind of a chronic conjunctivitis sometimes you'll see from this. The treatment really is warm compresses, lid hygiene. There are compounds. You can find them all over the place. I mean, they're on Amazon and stuff, and a lot of these are just simple things. Some of them have tea tree oil, which apparently works quite well, and ophthalmologists and opticians tend to like that. The one thing that's really easy, you can buy it anywhere, is baby shampoo. Remember, it's no tears. So you can put that on the lid and it works really well, and it's very inexpensive. Artificial tears works if the eye is feeling dry or anything else, and you really can't overdose on artificial tears. But I know some people try. Occasionally, it depends on what's going on. We probably wouldn't do this, but occasionally steroids, topical steroids in the eye, or topical antibiotic ointment with coverage for Staph aureus if you thought this was infected. Uh-oh, it won't go. Nope.
Try now.
Nope, it won't go forward. It goes backwards. Okay. So I would direct your attention to the top left picture. And what it's showing you is that there's a distinction between where you see the hair and lashes coming out. So the eyelashes are over on that one side towards the outside of the lid. And then the meibomian glands, which produce oils, are on the inside. And in between them, there is this, what is called the gray line. And you probably have never even noticed it. But there's a demarcation between outside the hair follicles. Remember, if you get a folliculitis out of that, I mean, you can get folliculitis anywhere. And that's why you would see in the middle picture that little start of a hordeolum or a stye. Those are usually painful and irritate people to great lengths. The other ones that you see down on the bottom left is a chalazion. If you kind of retracted the lid down, you might see it even better. But that's not really, it looks like it's infected, but it's not. As you can tell, there's no surrounding erythema. The middle picture down below is just meibomian glands that have been blocked up. You're seeing some of the material that's coming out of those. And then over on the right lower is another hordeolum, or I'm sorry, is a blocked oil gland. And so what you're seeing is not really infectious. What some ophthalmologists will do, if it's causing enough of a problem, they'll open that and get the material out, and hopefully it won't recall or return again. Yay. The other one you see not uncommonly is viral conjunctivitis. The term that everyone knows is pink eye. It is usually an adenoviral infection. It's usually adenovirus 3 or 7 in kids, 8, 11, or 19 in adults. However, there are some adenoviral strains of this that have been associated with epidermic keratoconjunctivitis, or EKC. Those are 8, 19, and 37. One of these you may see on the boards because it's adeno 14. Also can cause eye infections, but also associated with severe CAP as well as EKC. So if they tell you that's a test, and somebody's got pneumonia and they're not doing well, it's probably going to be an adeno 14. So some of the symptoms with this are watering and itching or foreign body sensation, light sensitivity, intermittent blurred vision. So if you're having that, the second through the fourth one, those are things you should really get concerned about for EKC and corneal involvement. And it's not uncommonly just because the way people sleep and the eye is becoming very watery that you can get infection in the contralateral eye. So It usually starts in one and can go to the other. This can be really nasty. Some people, just think, oh, it's a pink eye, and you don't really worry about it too much. But these can ulcerate, and they can ulcerate enough to where that they'll scatter light, and that if it's enough duration, it can cause permanent issues with corneal refraction. So that's something I would send either to an ophthalmologist or an optometrist. A lot of those are really good. My younger daughter had this several years ago, many years ago. And the first person saw her was an ophthalmologist who said, oh, it's no big deal, and, had these drops, and then went to another individual who said, this is crazy, it's getting worse. So got topical steroids and everything else, plus antibiotics in case it would get super infected and some other things. So it's another thing to just be cautious about. If it lasts a long time, and if they're saying that, their vision's getting a little blurry, they really need to be seen either by an optician or an ophthalmologist. The treatment, as we said, is really more, if it's not severe, if it's not EKC, is just support. Artificial tears are great. As I said, you really can't overdose on that. But severe keratitis really needs to be referred. This just gives you an idea, and you've seen people with this. You can even see follicular hypertrophy. Had this for a while when you're looking at the lower lid. It is a reddish eye, but this one is viral. The thing about it is that if this was in a hospital situation and maybe they were in for something else and you saw this, would you be concerned about it? So the question is, how contagious is it? Pretty contagious. I'd put them on contact, just to be honest about it, because anything that touches that eye is potentially infectious. It's like having, group A strep, that you can see this being transmitted to other individuals.
John, let me ask you a question when it comes down to it. If you have somebody that you don't know, if you have a type that I don't know, and let's say this is a pediatric hospital, and you're still considered about 14, would you also put them on droplet? That could be a question too. If it's pediatric, right?
Yeah, I guess, if it's respiratory, yeah, definitely. They should be on droplet. When would you use anything else besides droplet? Just an infection control question. So if they're going to have droplet nuclei, right? So with TB, if it's chickenpox, guess what else? What's the most contagious infection that we know about? Measles. And nobody gets measles anymore, right? No, because people are not getting vaccinated the way that has been recommended. So we're seeing more measles. So those are the things that really go on airborne. As a matter of fact, even though that no one ever really said it, that we, for SARS-CoV-2, were putting people on airborne, really didn't require it. And so that's why you don't see people going into a negative pressure room anymore if they get COVID. Okay, so we'll move on. Chlamydia conjunctivitis. It's obviously from contaminated hand contact. They may have a concurrent genital infection, or a partner may have had it. And due to chlamydia trachomatis, what strains cause STI-related chlamydia infections? The alphabet numbers. Is it A, B, C, or D through K, or L1, L2, L3, or those are all different. No, not for this. Nice try. As they say in baseball, swing and a miss. You're right, what? So it is not. This is actually with looking at the D through K varieties, the ones that you would normally associate with causing chlamydia cervicitis or urethritis. And again, when you're looking at women who have chlamydia, at least 80% plus are not symptomatic. And a lot of men, about 50%, aren't symptomatic with chlamydia, and you find it by screening. So they may not know that themselves or their partner has an issue. So the symptoms are either acute, where they are having issues, or subacute, and you only see this on doing an exam. Irritation, tearing, and photosensitivity. It's usually only on one side, usually unilateral. Diffuse follicular conjunctival reaction, which I'll show you in a second. They may or may not have a scant mucopurulent discharge. Same as that you could see in males who have chlamydia urethritis, they may have a scant urethral, more of a mucopurulent discharge, more mucoid really. And this is one of the few things that gives you a preauricular lymphadenopathy. associated with the eye. So the workup used to be, well, you had to send them to an ophthalmologist, and they would do chemostains of conjunctival scrapings, and we aren't usually the one doing a conjunctival scraping. I mean, my God, you don't carry an ophthalmoscope. Why would you have a number 15 scalpel and start scraping the cornea of their eye? I wouldn't. You can do direct fluorescent antibody staining of conjunctival scrapings. But now what most people do is that they lavage this into a small container from the conjunctival area and send it for a NAT or PCR, looking for chlamydia. So actually, that's a much better test than the others. It's certainly less invasive than the others. The treatment is like you would treat chlamydia elsewhere. It's oral doxy, 100 milligram twice a day for 7 days. The punitive dosing is tetracycline, 500 milligram 4 times a day. Anything that's 4 to 6 to 8 times a day is punitive dosing. I would only give it if I absolutely hated the patient, so usually I'm giving doxycycline. But if you can't get doxy, tetra could work. And actually, minocycline could work if you couldn't get doxy. This is one where that if this is truly chlamydia trachomatis, then you're probably going to have to ask histories about sexual contact and screen their sexual partners and treat usually epidemiologic. You can kind of see, and unfortunately I don't have a pointer to, well, I guess I could try it. It doesn't work, of course not. It's too light. They never work on TV screens. But you can see that little bit of follicular area, there you go, down in the conjunctival area. And that's what you can see with kind of more chronic disease. So now we move on to more interesting things, infectious keratitis or infections of the cornea. And there's a lot of things to think about with this. This is one of the, I would consider being one of the most unique and also problematic areas to treat in the body is the cornea. It's only a 0.5 millimeter thick. I mean, that's not real thick. And it has no vascularity. It gets all of its nutrition, oxygen, everything else from being open to the air. But it's filled, if you look at the stroma of this, there's a lot of sensory nerve fibers, and that's why when you get a keratitis, it really is inflammatory. Most of the refractive power of the eye is in the lens. So if you get, like me, if I don't wear my contact lenses, and so I have a variation in my cornea, and then so your vision is blurry, and you get to wear lenses, either contact lenses or glasses, that you have to refract that. Well, that's a problem with the lens. It's not so much inside the eye. So remember that anytime that something messes up with your cornea, it's really going to mess up vision. So there's 3 kind of things that we'll be looking at with that: epithelial, interstitial, and ulcerative. And out of those, probably ulcerative is the biggest concern for us. So the first thing is, do they have a history of trauma? Do they have a foreign body? The most important question to ask is, do they wear contact lenses? And not just to ask if they wear contact lenses, ask them how they care for their contact lenses, because that's a huge issue. And have they had corneal exposure? I mean, if you think about it, if it's somebody that we just happen to see, then you might ask about occupational exposures or recreational exposures. Is this somebody that's just went out and they decided to go skiing, and there's a new sun pack and the sun's out, and you can actually burn your cornea if you're not wearing some kind of glasses with that. You ever heard the term snowblind? That's what you get. Do they weld? Because if the welding mask is not sufficient enough to block a lot of the UV coming in, it can actually cause issues with their cornea and look just like this. But those are non-infectious. So what kind of things would be infectious? You can see the symptoms down below that. When you're looking at one of the things, the signs that give you an idea that something bad's going on, is that they get a corneal infiltrate. So if it starts getting more opacified and you don't think it's the lens doing that, it's not a cataract, there's bad things going on. You may actually see corneal thinning, which is a bad thing to happen with some of these infections. You might see corneal perforation with some of these things if people don't rush right in and take 2 or 3 weeks to kind of meander into the ED, because my eye's killing me, and you look and go like, oh, this is not good. So again, conjunctival injection, which is not real helpful. They may or may not have a mucopurulent discharge. They can have a hypopion. Anybody know what a hypopion is? Yeah, it's essentially debris, usually, polys and other debris that you see in the anterior chamber. Where do you see it?
Seems like to the bottom.
Yeah, it's almost like down in the bottom area. I'll show you some pictures. Sorry? Yeah, you can see it with some other things. Boucher would be non-infectious, more of a vasculitis. But sure, I mean, there's a lot of things that can do that. And our job is to talk with the ophthalmologist if they're seeing them and to ask some pertinent questions, because they're asking us for what antibiotics to use generally, although they have their own for the eye. And we may look at it kind of like, I don't know why you're doing this, but, and I'll talk about some of that in a moment, but some of this we may be asking for them to see and then wanting to know how to treat them because of this. The intraocular pressures can be either really high or low, depending on what gets messed up inside the anterior chamber. So when you look at what could be causing this, viral, herpes simplex, or varicella zoster, lots of different bacterial, fungal, and parasitic things can be going on in the eye. But the biggest thing, as we had mentioned before, is contact lens wear. And I'll talk a little bit more about that as well a little bit later. But the most common pathogens that you would see associated, especially with contact lenses, Pseudomonas, molds like Fusarium and Aspergillus, and Acanthamoeba. So a lot of different things to look at. These can certainly ulcerate the cornea. They can change the corneal texture, and they can cause perforation into the anterior chamber, which is a disaster when that happens. So just looking at this, and it's just so that you can appreciate, this is, if somebody hasn't already said, well, you need to go see an ophthalmologist, or I'm going to have you see an ophthalmologist right now, just by looking. The one on the left is not too hard to tell because, you can actually see a little bit of the slit lamp on there. So obviously these are at an ophthalmologist's office, but that's a nasty looking corneal ulcer. It's not clear what it's due to, but what's at the bottom part of that ulcer? Hypopion. Yeah. We had some nice phrases in ophthalmology that are hard to say, like everything else. And you also see a hypopion in the second one, again, with a corneal ulcer. And the biggest problem with that is they're going to see that. It's just going to mess up vision. It's going to blur vision. They can't see through it. It's an opacity. So they should be coming in to see you. But you see on the one on the right, where it's this huge ulcer, but then kind of scattered areas that are above that. So you've got more than half the eye involved. Just some other things. The upper left is me in the morning when I wake up.
Lovely lashes.
God, I hope not. Thank you. Thanks for noticing. That one actually is staphylococcal. So you can see a little bit of purulent material on the lids. I can't remember what the one on the upper right is, but obviously it's got a lot of discharge to that eye, and you can see an ulcer. You can't really see what's going on, with the iris or anything back behind it too well. It's not really that well illuminated for that. But the one at the bottom is really interesting. And I used this a long time ago. And there was actually an ophthalmologist in the panel. And and he'd seen stuff like this before. This is a really red eye, and you see that there's purulent material, and this person had gonococcal, conjunctivitis, and keratitis with this. That realistically is considered to be an emergency. What you do is you give them 2 grams of ceftriaxone, while you're on the phone trying to arrange for the ophthalmologist to see them. And they love it when you call Friday at 4:30. It's the best time to call. They're just sitting around not doing anything. I'm kidding. But this is an emergency, and if you can't get them in there, they need to go to the ED, because that can really perforate a globe fairly quickly in just a couple of days or so. So here's the issues, and a lot of this is just not good lens hygiene. That people, if it's a one-day use lens, they'll wear it for a week because they're expensive. And what happens is then the lens gets contaminated, and that's a bad thing. what some people will do is to use tap water to rinse or soak the lenses because it's expensive to buy, which it isn't. I mean, a big bottle of stuff is not that expensive. The other one that I did not put on here, but I have seen people do, is that the lens is causing them issues. So they'll take the lens out, they'll pop it in their mouth, and then put the lens back in their eye.
Oh, very moist.
And I'm just going, I'll be seeing you soon. Somebody will, because that is not a good thing to do. The other is not changing out a contact lens case. People think that, oh, well, I washed it out with water. What's in water? In tap water, in your house? Ask Dr. Canella.
No,
Ask me.
No.
You've got all kinds of things. You have amoeba, you have NTM, you've got all kinds of stuff. And it depends on also what the chlorine residual is in your area, because there can be all kinds. Everybody thinks that tap water is sterile. I don't know why they think that, but it certainly is not. The other thing is that you really shouldn't sleep, shower, or swim in contact lenses. Now, shower, I don't know. I mean, if it's an occasional thing, maybe not so much of an issue, but realistically, you should not be swimming in contact lenses, especially not out in salt water, because there are nasty, nasty things out in salt water, and that's the last place you want to get an infection is in your eye. So, if they're giving you in this soaking solution a new container, you should probably throw the other one away and use that, and not try and conserve on that. The other thing I would mention to you is make sure that whatever you're using, my preference is 3% hydrogen peroxide solutions, because they really do, I mean, they don't sterilize lens, but it is highly antiseptic. And the chance of you getting eye infection it's still a possibility, but much less than it would be otherwise. But they've gone a long way as long as you use the right thing. And then, unfortunately, the other part of the problem is people buying over-the-counter eye drops, and we've seen that being contaminated with bacteria and pulled from the market. And how do we know that that's usually an issue? As people start showing up to their physicians and saying, I got this eye infection, and they track it back as part of an outbreak, if you will, when CDC looks at it. I will mention to you, because this happened, as you know, last year, that fortunately, it's very uncommon, less than 1% of cases with Mpox. It was mostly conjunctivitis, rarely keratoconjunctivitis, which it's bad news, but it's good news that it's rarely on the cornea, which you don't really want. Conjunctivitis out of 528 patients was 6.6% and 0.4% of keratoconjunctivitis out of 264 patients that were followed in different studies. Just kind of can see down below. Usually, and that's why early on with this that I talked to pharmacy and said, do we have any topical trifluridine just in case? Because what we had was short stocked, and that means that it was going to expire within the next month or so. But that's okay, because if we see anybody in the next month or so that we have to treat who's got it in their eye, that we could get ticaviramab to give them systemically, and then topically give them trifluridine until we can get some more. But everybody and his brother was trying to buy up all the trifluridine for them just in case, because nobody knew what was going to happen. And then the announcement came out October 7th. What do you do with this of last year? And usually these resolve okay, but some of these people are still being followed up, and the results aren't published yet. So if you looked at the October 17th, 2022 MMWR, they had 5 cases of this, 4 resolved, and 1 was severe keratoconjunctivitis who had had corneal transplant. And so that one is still being followed. So just some of the things that you could see with that just looking at it, you wouldn't know exactly what was going on, although getting a sexual history may give you some idea what's going on. The bottom one down there looks more like a viral issue. So these are just some of the things, if you had genital lesions, would make you think that there was hand contact and hand transmission with this to the eye, which is really scary if you're looking at, especially with this viral infection. Herpes simplex, I think most of us, recall learning about this a long time ago. It can either be with primary or what we would kind of call secondary, but it's also called reactivation herpes simplex. So if you get the primary infection, if it's genital, it's usually worse than having it If you already had HSV1, let's say, and then you got infected with HSV2, the second infection is less severe, generally, not always. So it can be that way in the eye, and it can reactivate in the eye in a few people. So that's part of why you might see some people that are on prophylaxis trying to keep it from recurring. Obviously, it's usually in one eye. It's monocular pain, photophobia, tearing, blurred vision, and if it comes on later, if it was a secondary infection, it might be less painful, more of a foreign body sensation with some blurred vision and maybe some photosensitivity. When you look in the eye, you see this vesicular blepharitis, follicular conjunctivitis, again, a preauricular lymph node. What else can give you a preauricular lymph node that we talked about earlier? From eye infections. Chlamydial. Okay. The other thing with this is staining epithelial dendrites, which I'll show you a picture of. But it doesn't have to be this dendritic spread. It used to be thought that the dendritic spread was because of what your eye normally does with the lens, that you get a small corneal ulcer, but every time that you move your eye, the lid, it would move it on down. But most people think that's really not the case. It's just meandering through your eye, looking for a nice home. So, the other part of this that's a problem is punctate keratitis and these large geographic ulcers. And once you get enough involvement, you can decrease corneal sensation, not feel when you're, and people will take a Kleenex and try and wipe their eye, which is the worst thing. You have to tell them, don't wipe your eye, blot, because they'll fold a piece of Kleenex, the eyelid will not necessarily come together, and they'll wipe it. And so when you take that Kleenex, it feels so soft in your hand, that little corner is like sandpaper across your cornea, and you can really mess up an eye by just wiping with it. So it's always blot the eye, not wipe. So usually I would recommend referral to an ophthalmologist as soon as you can. They may end up doing debridement on it, and then there's a lot of different things can be used. Some of the older things have been to use topical trifluorothymidine or Viroptic. As you can tell, it's the easiest one to use. It's only 9 times a day, drops. The other one that was a little older was Vidarabine or Vira A ointment. It's an ointment, so of course it's going to be sticky and stay there longer, so it's 5 times a day. And more recently, there's Ganciclovir ophthalmic gel, which is 5 times a day. It's a 0.15% solution of that in the gel. They also had recommended using a cycloplegic agent. What is a cycloplegic agent? What does it do? Does it make the iris, your pupil, small or large? Well, one of you has the right answer. Let's vote. So no, it's you're trying to make it a little wider open so that you can see. And usually cycloplegic agents, they don't always have to be used, but you might see that used.
Isn't that the same thing as a mydriatic?
Yes, because there's mydriasis and what's the other one? Ptosis. No, ptosis is
the eyelid.
So if you're what?
Dr. Canal said meiosis.
Yes, meiotic. Yes. It's not mitosis. I had a resident tell me, well, I put those mitosis drops in his eye, and I thought, well, he's going to have 3 eyes around it. I don't know what's going on with that. I know. I like it when people mispronounce words. I mean, I'm sorry. I hate to make. It's for. It's mainly patients trying to talk medicine to you. You may end up using steroids, which you might think would be counterproductive if you've got a viral infection, but it really calms down, some of the inflammation that's going on. Remember, you've got this infection in an area of your body that has no vascular supply. I mean, it's getting all the nutrients either from the anterior chamber or from the outside, from the drops. And a lot of those drops penetrate really well. But steroids can calm it down, and it's not uncommon to use, and actually people do better a lot of times with steroids than without. I don't know that most of them get oral steroids, but I know topical steroids are used not that uncommonly. And then what you might see is the ophthalmologist wanting to put them on prophylaxis, trying to prevent a recurrence. And the data with that's not huge, but there is some data with that. And if you think about it, well, if it was your eye, would you mind taking prophylaxis so you didn't get it again in that eye? Acyclovir is a relatively really benign drug to take, even long term. So we would probably not be too concerned about doing that. So here's what you can see. At the top, you see this dendritic form that's stained with rose bengal. So you can see it without having a fluorescent light. You can use fluorescein. Somebody coming behind me? Oh, I didn't know.
Very good.
You were looking at me. Okay. The bottom left one is using fluorescein. So you have to have a little fluorescein piece of paper, touch that to the cornea, and it see that if you, even without a fluorescent light, there are little fluorescent pen lights that one can use to see that. And then here's what your body tries to do. It's trying to heal itself. It's trying to heal that corneal ulcer. And what does it do? It's growing blood vessels across your cornea. While that's helpful in treating the infection, it's bad because you can't see through it. So this is what you really don't want. And you know, this may end up having a corneal transplant or other things, but this is where, you know, that you have to be careful with these. And I highly recommend that an ophthalmologist evaluate this and guide the patient and us as to, you know, how can we help in these situations.
To diagnose, can you do like besides the characteristic, but can you do like a lavage for PCR?
Yeah, I haven't seen people doing that. A lot of it is just looking at it, but I'm sure you probably can. I mean, now that we have PCR and it doesn't have to be, it's like, you know, the old ones were a direct DNA where you had to get a lot, you know, and that meant that you had to swab it or something else, and people aren't going to like it because it hurts anyway. This, you probably can. Have I done that? No, but. So we already talked about contact lens use, and so I just had that back in there because of the Acanthamoeba keratitis, which we mentioned earlier. The other is people wear their contact lenses if they're in a hot tub, and then some of them will get, you know, when they go underwater in a hot tub, if the hot tub isn't cared for properly, which means it's not chlorinated or brominated appropriately, you don't have residual in there, and what can happen in that hot water? It's up to maybe 104 to, if you really like it hot, 110.
Soup.
It is a soup. And what does it contain? It contains exfoliated cells from you, oils, other things from different areas of your body. And what's one of the big things that likes to live in hot tubs that you can see causing a folliculitis? Pseudomonas. So you could get that in your eye. And you know how contact lenses, part of it, they were created as a bandage for the eye, the hydrophilic ones, because instead of putting drops in your eye 9 to 12 times, you know, like every hour, that you could put this on your eye and act like a patch, and the drugs would stay on the cornea. And then it was adapted that, hey, you know, sometimes people saw better with this bandage on their eye than they didn't. So we saw, you know, different kind of contact lenses. I started wearing contact lenses when I was in high school, and they were the old non-gas permeable ones. They were polymethyl methacrylate. You could only have them in your eye for at most 8 hours, because if you didn't, they weren't permeable to oxygen. How does your eye breathe, if you will? It doesn't. It only gets it through tears. So I was told you do not leave them in more than 8 hours. It was a Saturday. I was watching TV. I fell asleep. I woke up and felt like the cornea just peeled off my eye. It was the most horrible thing ever. And then trying to get them out. There's some things in your life you don't want to relive, and that was one of them. So, again, taking good care of contact lenses, not swimming in hot tubs if they're not very well cared for. But this one, you really have to send to an ophthalmologist, because they're going to scrape for amoeba and see if they can see it either by confocal microscopy, which is one of the things that is being used more than that. And you need to see what kind of amoeba is this. Usually it's going to be Acanthamoeba, but there may be a few others that might cause this. These are really tough to treat. They're using topicals for the vast majority of this, topical biguanides, which is like chlorhexidine, and polyhexamethyl biguanide, which is an older compound, but people, you know, say that it just works really well. aminoglycosides, but peromomycin and neomycin instead of what we would think about, being systemic aminoglycosides. The diamines like propamidine and hexamidine, sorry. And now some of the newer data that's coming out, and some of these have been very difficult to treat, has been some people said they used oral voriconazole and had a successful outcome, but the levels in the eye are not that great. But using 1% topical is actually available. And with Acanthamoeba, it seems to be a really helpful adjunct. And usually they're using all kinds of drops multiple times a day. They use them probably 9 times to sometimes early on, even every hour, which means you have to wake up to put the drops in your eye. And you hit them hard early on because you're killing the cysts, you're killing the amoeba. Then what happens? Then they insist, and that's where it's a really chronic phase with this. The treatment's going to last probably 6 months to a year. We actually had a fellow many years ago who had this and was telling me, I said, so what got you interested in ID? He said, well, I had Acanthamoeba keratitis. That got my attention. So yeah, that was Patrick Kenny. And he had no residual from it, fortunately. But he said, yeah, it took about a year and I finally got rid of it. So you do not want to get this. The therapy is difficult. It is very time consuming. And it just means taking care of your contact lenses. But there are other things, having a foreign object, et cetera, can do this. And so you can see some of it, but some of this, you can't really see the ulcer too well from the pictures. You can on the bottom, but the ones on the top, the one in the middle, you can kind of see maybe a little bit of a crescent. And that's about all you can see. And an ophthalmologist is going to do like they do on the bottom ones on the bottom, the second through the last one there, is use a slit lamp. And they can actually see this much better with a slit lamp than we are with a pocket light. Although you can, if you do it right, you can see it.
This is the end of part 1 of this lecture. Join us next week for part 2 as the lecture continues.